Hello and welcome to Next Phase, where we examine the intersection of health and technology and talk about the future of our health system. Today I'm delighted to welcome Dr. Gareth Baynam. How are you, Gareth?
Lovely to see you, Simon.
Gareth and I have known each other for some years now. He's a clinical geneticist, works out of WA, and currently one of your roles is with the West Australian Department of Health, but he's also a genomic policy advisor, a patient advocate, a clinical scientist, an intrapreneur. Gareth, do you want to talk a little bit about the work that you do and the career that you've had to date?
Thanks, Simon, and thanks for that really gracious introduction. Well, I guess it's simply, I'm a paediatrician that trained to be a geneticist, and really my focus is on equitable health, and that drive to equity, that drive to serve those that need it the most, and the most is really what underpins what we do. And been exceptionally fortunate with exceptional people and great teams in a fantastic ecosystem that we have in Western Australia, and to really be led by the needs of patients and their families.
Gareth, I came across you. I had to go to the US before I actually encountered you. I was working with the Global Commission to end the diagnostic odyssey of children with a rare disease. And there are some surprising parallels between the endemic, which is rare disease around the world. We've got 350 million people living with a rare disease, and many of them have families, so it impacts many lives. But there are parallels between that and the situation we find ourselves in today with COVID, because there's restricted access to medical services, there's living with uncertainty, there's policy ambiguity and how to use technology to get around some of those. I'd love your thoughts on how your work and experience with rare disease might translate to how we work through this immediate COVID crisis. And then what do you think some of the lasting changes for our health system going forward are?
Simon, so you imagine a situation where you're living in complete uncertainty, in isolation, that with a global crisis that requires international coordination, a committed public health response, social innovation, economic adaptation that needs new regulatory processes, new diagnostic implementations. And then you need to accelerate how you develop treatments and vaccines. You have to change the game plan, and you have to change the game field to deliver those. That is the situation of the global endemic of the 350 million people living with a rare disease, and it's the same dynamic. There's so many parallels between that and managing pandemics, and COVID is an absolute prime example for that. It's a totally devastating world event that's had unprecedented impact in recent times. At least we've had pandemics previously. And I think we've seen these parallels also between managing the public health response needed to manage epidemics and endemics, and HIV would be a classic example of how that's changed the landscape, how that's changed things like intellectual property management with shared patenting or various other changes. So I think that the joint opportunities that both the rare disease community has and the community at large through COVID and other infectious diseases is to look for those synergies, because there are so many, and we really can learn together and from each other, because we each coming from those camps, we have decades or even centuries of experience in managing these things. So I think it's an extraordinarily powerful time for systematic and systemic change, and also for a recalibration, how we connect to each other and our own human values. I think one of the really marvelous spin-offs of the terrible devastation of COVID is seeing the connectivity between people and the value that's placed in that, and the value that's placed in the essential workers, and putting politics aside to fight a common enemy. So the parallels are enormous, and I think the opportunities for everybody, including people with rare diseases, are undeniable.
So we're all getting a little taste of what it's like to live with a rare disease as citizens through this COVID time. So hopefully that generates a bit of empathy. But can I get your take on what it means to be someone living with rare disease through this COVID time? I imagine that places additional burden on their already stressed lives.
Yeah, I absolutely. What we've seen, and there's been some great work predominantly out of Europe by IRDiRC with about 5,000 participants surveyed to look at exactly that. And so we've seen 9 out of 10 rare disease with at least one or two interruptions in their care. We've seen their surgeries, their fire care being removed because the units or hospitals providing that care have been closed. We've seen access to life-saving medicines stopped, so there have really been the mental, and I think one of the huge impacts out of this, and which will be both an immediate impact and a massive long tail, is the mental health impact. And so I think there's a lot to be done. On the positive side, I think the embrace of telehealth and virtual clinics, and the acceleration of the ability to provide that, because that's always been one of the biggest barriers, is actually at a health system level not having the technology to actually do that well, because the system crashes or it's not able to actually do the simple things that you actually need to do in a clinical visit. And so I think that is a real positive. We've seen with clinical service that, in fact, in the clinical genetics service, our numbers have stayed the same because we've been able to flip so much of it to sort of telehealth and virtual health. That said, there are limitations, and I think what we'll also find is there are a number of appointments which really do require face-to-face are essentially being doubled up at the moment. So for some of the telehealth, it's buying time until we can provide those face-to-face services again. So there's a sweet spot, and I think we're learning where those sweet spots are and where those limitations are. And one of the other things around the telehealth that I think was a bit unanticipated was, from a clinician point of view, how exhausting it is. So I think the experience is that it's actually more exhausting doing telehealth than face to face. So I'm not sure why that is. I have ideas about why that is, but that seems to be a common feeling. So I think the positive is the use of telehealth and virtual clinics, and how that can really help, and finding out what the best use cases are. Some of the biggest issues around that will be internet access. I think that we see where we're seeing a digital divide with telehealth is really around those remote regions. So we often can connect, but the connections repetitively drop out. And so you can imagine trying to provide a service where you either lose the connection or it's repetitively dropping out during the appointment. So the silver lining is definitely the identifying the sweet spot and the increased use of telehealth, and also pointing out what the rate limiting steps are for that, and that's great because then we can address those rate limiters.
When I think about clinical genetics, I think the resourcing problem that we've got all across healthcare becomes most acute. In clinical genetics, under the traditional model, you've got almost unserviceable demand in that there's so many people and there's so few people at the pointy end who can provide that service. I look at technology as a way of somehow meeting that mismatch of supply and demand. Telehealth is one way that you can get out there. But I also think that we need to flip to a more adaptive health system that encourages empowerment and self-service aspects. And I potentially see other patient groups as community support and cross-training functions. Is that the way you see it, and within rare disease? And do you see a greater role across all of healthcare for that?
Absolutely. I think rare disease is an exemplar domain for implementing these sorts of solutions. We've seen that repetitively. We see it on the other end in terms of discovery of new medicines. You know, half of all new medicines come from rare disease research. 1/3 of biomedical innovation comes from rare disease research. So this is a proven concept, and we've seen statements from, for instance, DG Sante, European Commission, talking about rare diseases as being the exemplar of how to rebuild medicine. And yes, it's the community voice, it's the patient empowerment, the patient input that necessarily has to be the driver, and therefore better integrated into how we do this. And to achieve scale, we need better digital workflows as well. And that because we're not going to be able to suddenly grow a whole bunch of clinical geneticists or genetic counsellors rapidly. It takes a long time to grow these people and develop them and train them. But what we can do is increasingly work together in partnerships, and we do need the tools that enable that to happen. So I think the biggest roadblock in clinical genetic care is actually the flow of phenotypic information. So in a way, the biggest overhype for clinical genetics in particular and for genetic medicine is genomics. Genomics is transformative, there is no doubt. Genomics does deliver step changes, there is no doubt. It is wonderful. However, there is so much focus on the genomic testing portion of the equation, or the genomics itself, and far less focus on how do we innovate the workflows and how do we allow that flow of phenotypic information, because the phenotype in the end is what we deal with. It's what patients have, it's how things manifest. It's their stories that they tell us, it's how they live their lives and how they experience their disorders in their communities. So it does guide diagnosis, it has to guide therapy, and it has to guide social services, disability, education. So the efficient flow of phenotypic information between patients, doctors, health systems, laboratories, and then through to social services and back is the key to scaling to scaling this scenario. And unless and until that is a concerted focus, we will always be rate limited. The second place we will always be rate limited unless and until it's a focus goes back to those that need it most. And I particularly think about people in remote areas, and I think about Indigenous people. And I'll give you a COVID example. I'll give you two COVID examples. I'll give you one of a rare disease flip to COVID, and I'll give you an example of COVID dynamics that speak to why you need to concentrate on those that need it most. So the COVID flip, if you like, is we have a project called Life Languages, which is about translating Indigenous languages into medical terminologies. It focuses on rare diseases, but can be used for any medical specialty across life. And when COVID became an issue, we realised very quickly, not just us, lots of people, that remote Aboriginal communities are at particular risk and needed information in language. So we quickly flipped that network of people, because it really is a network of youth and elders working together to create community education resources in language for COVID. Really simple, one page, plain language, in language. And those were implemented in multiple languages in very remote communities in 48 hours. So that's a flip from rare disease to COVID. Now let's take the other aspect. Now let's look at what are the ultimate rate limiters to, if you like, full return to economic activity or fully opening up borders. It's actually going to be the most vulnerable patients in our communities, okay? The ones that we need to protect the most. So that is actually the rate limiter to total return to, if you like, normality. So, and this is the same for any aspect of medical care. So the paradigm needs to be flipped, the funding needs to be flipped, and by focusing on those areas at most risk and at most need, you will develop robust adaptable solutions that will work for everybody, and that mean we can respond as a society totally to health crises faster and return to normality, again, whatever normality is, quicker. And so I think COVID again has highlighted that. If I think about in my own state of Western Australia, the last place within our borders, within our state that will be opened up will be the top end of our state with very remote Aboriginal communities. And again, it actually comes back and shows you how the community itself often innovates and adapts well ahead of any system. So in many ways, the Aboriginal communities in Western Australia adapted faster than everybody else. They've experienced the devastating effect of infectious diseases before. So they're very quick to say, look, we need a systematic response. We need to lock down. We need to educate, and we need to communicate. And the Aboriginal Health Council of WA, working together with communities and the Public and Aboriginal Health Division of the WA Health Department, really did a marvellous job of working very cohesively and very quickly, and really in many ways ahead of everybody else. So I think again it's unmasking that paradigm, which this is not a new concept. This is, necessity is the mother of invention. So it's just that's being surfaced again through the COVID dynamic.
Wow. Gareth, I told you 15 minutes ago fast, and it has. It's extraordinary to hear your insights from this domain, because they're so very relevant to how our society is struggling to adapt, and it gives us some guidance about how it needs to. In the last minute as we wrap up, is there anything else that you'd like to highlight? Because this has been really instructive.
Maybe just a message of hope. I really, it's just amongst the terrible devastation of COVID, and it's been terrible devastation. We cannot overstate that. The shining lights of humanity and what it is to be a person and a community. Let's continue to embrace that. Let's not let the rubber band snap back. And turn that into meaningful, sustainable, compassionate change.
What a lovely way to close. Gareth, thank you for joining us on Next Phase. Your insights are most appreciative, and we look forward to seeing you in person when all of this blows over.
Lovely. Thanks, Simon. All the best.
Thank you.